All right. And we are live. Welcome, everyone who's joining us live. We'll wait for people to start rolling in while we do that. Let's get some little introductions going here. My name is Cole Seifer. I'm a lot of things at the company. I'm one of the co-founders. I'm the marketing director. I make sure patient success is running smoothly. And I'm joined here with the super brilliant Dr. Colin Renaud.
Hey
Colin,
everyone.
why don't you give a little background on yourself while we're waiting for people to roll in and how you got into this space of medicine, being functional medicine?
Sure. My background is quite diverse. I started my career more in the integrative alternative medicine world. My doctorate's in chiropractic medicine. I'm board certified in natural medicine and anti-aging. I have medical training as well to sort of extend my clinical abilities. So I got into functional medicine really as a extension of myself. It's how I live my life, and I've always been into fitness and bodybuilding. So I never really melded well in the conventional medical space. I was always, you know, apt to use natural remedies or lifestyle interventions. So it was just an easy fit for me. But I've done a lot of additional training to really give myself a lot of tools in my toolbox to do various things. So yeah, that's where I'm at.
Awesome. Well, appreciate you sharing. So
Yeah.
today, super exciting episode. Normally we do two segments, but this is such a big topic, like a lot of the topics we cover, that we're just going to talk about these kind of things for the next 45-ish minutes here. So we're going to be talking about high blood pressure, statin medication, and overall motivation or lack thereof,
Hmm.
and how all these things are connected. I know there's so many patients that come to MedMatrix every single day wanting to get off statin medications. They go to their doctor with all these other issues. The only um, recommendation they walk out of the primary with is, "Yep, everything's fine. Just take some high blood pressure medication," and that's really it. So we're going to
Yeah.
talk about the root cause of that, what we do with patients to help them fix these issues, so on and so forth. So um, let's start off with like just a super hot question. Dr. Nard, when are statins good and when are statins bad? And what are statins?
So statins are a cholesterol lowering medication, and they are very widely prescribed. They're one of the most commonly prescribed medications right now, and a lot of our patients are on them. So I'm not saying that's a good or bad thing, but they do. There's a lot of controversy around statins because of side effects, and there's a lot of new research on what really causes heart disease and cardiovascular issues, and do we need to lower cholesterol as much as we think? So, um, statins, like I said, they reduce cholesterol synthesis in the liver, and they also reduce LDL or the bad cholesterol, if that's we know what some people know it by. So, when someone has had a heart attack or a stroke, they can reduce a recurrent event, and that's really the point. So statins make sense for someone with a prior event, if they have high inflammation, if they have insulin resistance, but lowering cholesterol doesn't always address the root cause. And one thing about cholesterol really that we need to ask, and I ask myself with patients all the time, is, you know, um, it's not like how high is the cholesterol, it's why is the body making or retaining more cholesterol? So that's really what we in the functional medicine world are trying to understand. And I can respect the use of statins, but a lot of times they are overprescribed, or the person's cardiac risk is very low. So the point of the statin is maybe unclear from my perspective. Their doctor put it on them because they might have high cholesterol, but their cardiac risk may be low, or their cardiac risk may be related to something else, which we'll dive into, like what drives cardiac disease, right? Is it cholesterol or is it other things? And that's a big part of a functional medicine approach to heart disease and high blood pressure.
Yeah, gotcha. So
Yeah.
let's just dive a little bit more into cholesterol. Like,
Yeah.
is cholesterol bad? Because our body needs cholesterol, right? I mean, a lot of
Yeah.
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 So walk me through that.
Cholesterol's,
Like,
yeah, it's highly demonized. I mean, and high cholesterol is not always harmful. So Cholesterol is really essential for cell membrane integrity, especially in the brain, and also production of hormones. So in our clinic, we deal with a lot of hormone imbalance, especially with low testosterone in older men, perimenopausal and postmenopausal women. So you need cholesterol to make hormones, testosterone, estrogen, progesterone, even cortisol, your major stress hormone. You need cholesterol for vitamin D synthesis. You need cholesterol for your immune function. So the thing that we try to understand is the cholesterol bad? Is it doing something bad for the body? And I have had quite a few patients over even the last few weeks where we do their blood work that we do for all of our patients, our expanded panel, and their cholesterol is really low. They're on a statin, probably usually a high dose, and their total cholesterol, which an optimal level is, a little less than 200. That's sort of what the reference range is. I've had patients with cholesterol levels at like 110, and it's like, this is really low. So when we talk about optimization of hormones and vitamins in the immune system, we really need to understand the presence of a statin in their risk. So some of the really interesting things, though, and we can talk about this more, is that according to recent data, total cholesterol and LDL markers are very poor predictors of cardiovascular disease. We really are looking at things like insulin resistance, inflammation, and then the cholesterol particle size, and if it's oxidized or not. So a lot of people with high LDL or the bad cholesterol have low cardiovascular risk if their metabolic health is optimal. So when we assess people's cardiovascular risk, it's really about insulin resistance, prediabetes, all of that. So that's a really important part of it.
Wow, that's really interesting.
Yeah.
Um, so let's
Yeah,
dive
this
more
whole
into LDL.
demonized thing we need to
Yeah.
like get away from. Yeah.
Yeah, let's dive more into LDL. Like, when is LDL actually bad? Because you hear all the time, bad cholesterol, bad cholesterol. I need to get my cholesterol down. Um,
Yeah.
yeah, can you elaborate on that?
So LDL, so some of what the new research is showing is that LDL, like I was saying earlier, is not a great marker of it's a poor predictor. So we really want to try to use other markers that we often, well, we do for everybody. We run in all of our basic panels for patients, things like inflammatory markers. We want to look at the LDL particle size and number. So it's not just the total LDL, it's the size, how much is floating around, if it's oxidized or not. And then we also want to look at VLDL, which is very low density lipoprotein, because VLDL is more associated with plaque formation. So as insulin resistance increases, VLDL production is heightened, and then LDL becomes smaller, which increases plaque formation. So that's really where we're trying to understand the role of LDL. It's a very poor predictor by itself. But most people, when they see their doctor or their cardiologist, if the LDL is high, above 100, 120, they're going to be put on a statin. So, and then if their total cholesterol is above 200, they're going to be put on a statin. But the real question is that LDL being high causing a problem? And that's the bigger question.
When does at what point does high LDL actually become a problem? Or what
Well,
other things have to be present for LDL to then be a problem? And LDL can actually be as high as you want it, as long as these
right.
things stay at a certain level, if that makes sense.
Yeah, so that's what I was saying is most people with high LDL, they can have very low cardiovascular risk if their metabolic health is optimal. So we're really looking for things like insulin resistance, if you're pre-diabetic, if there's inflammation in the body. Inflammation damages the endothelium. We've talked about the endothelium on this podcast before. It's a single cell layer that lines the inside of blood vessels and also organs. And inflammation of that can drive damage to the blood vessel, which can create plaque. If you're eating a lot of ultra processed foods, if you're eating seed oils, if you haven't, some sort of environmental toxin exposure. So the thing to remember is that cholesterol by itself is not harmful. The problem is when there's inflammation involved, the cholesterol molecule starts to stick together. And when it starts to stick together in the presence of insulin resistance and endothelium damage and really poor nutrition input, that's when we start getting plaque. So that's really from a functional medicine perspective, what we try to understand is, okay, if the cholesterol is high, is it causing this plaque problem? And if it's not, then we mitigate risk based on the patient's history.
Okay. So walk me through kind of your clinical experience with this. How often are patients coming in on statins that they
Oh
don't need to
boy.
be on?
Um, so a lot, actually. A lot of people are on statins. So I don't want to demonize statins. I'm not anti-statin. I'm anti-overprescribing of a medication to meet a guideline, right? And that's
Mhm.
really what's done with statins. Anybody over a 200 cholesterol, you put on a statin. Statins are not benign. They cause a lot of side effects in people, and we can talk about that separately because it's really important. But um, one thing we have to look at is, like I said, their medical history. Do they have a prior heart attack? Have they had a stroke? Because those things, yeah, it can reduce their future risk. But we also want to look at, like I said, the insulin resistance is a big thing. Are they pre-diabetic? Do they have high inflammatory markers? Do they have hormone imbalance? So that's really the biggest part. And then also there's influence of minerals, certain vitamins that can influence poor cholesterol metabolism. So that's really the big thing from understanding a patient. And there's other ways to assess cardiovascular risk that's not just statin. We have imaging study tools that we can utilize. There's something called a heart CT with a calcium score that is one of the most sensitive studies from an imaging perspective to evaluate coronary artery disease risk. So doing something like that is really important in someone that maybe has high LDL or high cholesterol. And if their cardiac calcium score is 0, that means they're not plaque forming anything. So do we care if their LDL is a little high? Well, maybe we don't. If they're non-diabetic, if they're not pre-diabetic, if their hormones are balanced, do we care if their cholesterol is a little high? I wouldn't. But it's all about risk mitigation for patients.
Awesome. Cool. And thank you for everyone who's joining live. If you're just joining us now, none of this is medical advice. This is just for education purposes
Yeah,
only. We
education
appreciate
only. Yeah.
all you guys joining us live. So, all right, let's go a little deeper here. So, um, when when does LDL get to a point where you start to actually get concerned?
Well, it's not that simple, Cole. It's not just get concerned if LDL is high. Like I said, and I've said, for the last few minutes, it's about other factors. So I've had I just had a patient yesterday, actually, male patient, and he was fairly young, and he was my age, so I'd say he's fairly young. And he has a history of high cholesterol. His total cholesterol was like 280, and his LDL, I don't remember his LDL, but it was pretty moderately elevated, maybe like 170 or something. And he had like a cardiac event where he had some chest pain overnight. He went to the hospital. He had all the workup done, an echo and a calcium score, and he wore a Holter monitor, and his heart was totally clean. And his doctor recommended a statin, and he sort of asked my opinion, and I said, well, if all of your cardiac function tests show that you have absolutely no plaquing, you're not pre-diabetic, your hormones are really good, you work out, you eat really well, why do we want to lower the cholesterol? So in my opinion, we don't, because how would it add to his health if we lowered it? And like I said, most of the time from a medical perspective, lowering the cholesterol is to meet some sort of metric, an algorithm, right? It's part of the routine that's done. So just saying that LDL can be high and when should we do something about it? It's a lot more complicated than that. And that's why we're talking about this.
Gotcha. And I
Yeah.
apologize. I asked the question in a way
No,
that
it's
seems like I
fine.
wasn't listening, but that was a great example. That's kind of what I was
Yeah.
getting at. I guess could you explain? Let's explain some of the correlations. So, what's the correlation between insulin, blood sugar, and cholesterol?
Yeah. So when when you have insulin resistance, and really what insulin resistance means is that your insulin, which is the hormone that regulates your blood sugar, when you feed the body with too much sugar, your insulin is not able to control that sugar load, and your insulin becomes less sensitive to the sugar. So when you eat more, you're not able to control it. So what we're seeing in a lot of the recent data is that insulin resistance is the most common cause of high cholesterol and also one of the most common causes of high blood pressure. So when we try to understand a patient's risk factor for cardiovascular disease, that's like the number one thing we have to look at. So and same thing, like I said, for high blood pressure. And this is a part of it. There's a lot more things going on, but one of the biggest things is insulin can increase sodium retention, which can lead to fluid expansion. And that's a very common driver of high blood pressure. So if we're trying to understand a patient's high blood pressure and they're diabetic or pre-diabetic, well, that insulin resistance is probably causing a fluid imbalance. So, treating the high blood pressure with medication is obviously warranted, but the root cause is probably treating the metabolic dysfunction.
Gotcha. So what are
Yeah.
what are some of the longer term side effects of something like a statin medication with the, result being
Yeah.
prolonged cholesterol that's really low?
Yeah. So I mentioned earlier, some of our major hormones, steroid hormones and processes in the body are driven by cholesterol. So by reducing cholesterol, you're essentially affecting your production of estrogen, uh, your production of progesterone, testosterone, cortisol, vitamin D, which could all lead to low libido, fatigue, poor stress tolerance, mood issues. And one of the biggest things that statins do in terms of, we sort of labeled this podcast about motivation. Um, One of the biggest things that statins do is they block the production of coenzyme Q10, which is a critical molecule for cellular energy production and muscle function as well as cardiac performance. So when this molecule is reduced, it can result in fatigue, exercise intolerance, brain fog. And a lot of those symptoms are things that patients present to their doctor with. And, if they're in their 60s and they tell their doctor, "Oh, I don't exercise as well, I'm fatigued, I'm brain fogged," a lot of doctors might give them the answer, "Well, oh, it's just aging." It's like, well, maybe it's not. Maybe it's a side effect of your 80 milligram statin that you're on, right? So statins also don't improve insulin resistance. So, and it also may worsen insulin resistance. So if we're trying to look at insulin resistance as a major common root driving cause of cholesterol issues, and then we're taking something that might make it worse, we're really start to like spin our wheels here. So, I see a lot of side effects from statins, and it's hard in patients because it's not my job to be right and overturn what their doctors tell them, especially like a primary or something. But it's my job to educate and say, okay, this is what I'm seeing. This is other comorbid issues we have going on. And we really need to understand the risk of cardiovascular disease in that person and what they have going on. So it's all about educating and trying to understand the side effects and the risks as well as potential benefits.
Gotcha. All right. So let's
Yeah.
do like a example case study because I'm sure you see
Sure.
patients similar to this a lot. So a patient comes
Yeah.
in, they're on a statin medication,
Hmm.
um, and they have low because of the statin medication. They now have low LDL.
Yep.
They're overweight, poor insulin resistance,
Hmm.
low energy, low not motivated.
Hmm.
What are the first things that you're looking at, and then what would the typical type of plan for that patient be?
So we need to get more information about them, right? And that's what we do from every patient at our clinic at MedMatrix is we need to understand all their insulin markers, right? Their insulin itself, their fasting serum glucose, their hemoglobin A1C, which is a measure of how well you control your blood sugar. We need to look at more cardiac markers, right? All the different types of lipoproteins, apolipoprotein B, which is responsible for plaque formation, lipoprotein A, which is more closely associated with cardiovascular disease than just LDL or total cholesterol. We need to look at their vitamin levels, right? Their ferritin, their vitamin D, their B12, their hormones. So with a patient like that, it really becomes, okay, they're on a medication to help kind of stabilize them so nothing happens to them. Because their doctor recognizes, and doctors do recognize, I'm not saying that they don't, they recognize that people are overweight. They recognize that people need to make better life choices. But when your doctor gives you 5 minutes or less in an appointment, which is most primary cares nowadays, the primary care realizes that all this stuff has to be done, but they don't have the time nor the energy nor the experience to educate and spend an hour talking about diet, talking about all these things that the patient needs. So stick them on a statin. It will kind of like keep them safe, if you will, maybe prevent a heart attack. There's a lot of medical legal stuff going on here too, but it's really about understanding all of these things together. So for a patient like that, it's starting with the basics, the nutrition, the diet, the weight issues, the insulin resistance, and then you have to build from there. So it's not my job to take people off of their medications from other doctors. It's my job to educate, as I said, and start working on the root cause problems. And then eventually they could come off their medication. And I've done that a lot with patients. We have a talk with their doctor and say, hey, we've done all this work. We've lost 50 pounds. We're not pre-diabetic anymore. Can we stop the statin? Great. And then we move on. So that's how the patient like that needs to be approached.
That's
Should
fantastic.
be. Yeah.
Yeah. Can you elaborate a little bit more on, you said medical legal
Yeah.
issues with the 5 minute visit, the high blood pressure. Can you elaborate more? Like, what do you mean by that? Like, why would a doctor almost be forced to put a patient on a statin medication?
Well, doctors are forced. Healthcare providers are forced. And another disclaimer, this is not legal advice either. I'm not a lawyer. Cole's not a lawyer. We are not lawyers at MedMatrix. So, but the practice of medicine is a legal relationship as well. So there are certain parameters that need to be met if you practice medicine. So especially in the insurance model of healthcare, and that's why a lot of healthcare providers are frustrated in the insurance model, because the insurance company dictates what needs to be done. Everybody's cholesterol needs to be under 200, so put everybody on a statin. And if you're not on a statin, and you have a patient with a cholesterol over 200, we're going to dock your pay. That happens, by the way. That's a little bit of a secret. I have colleagues that's happened to. If you have people that are pre-diabetic and you're not on metformin, which is a diabetes medication, the company you work for will reduce your pay by like $50 to $100 a patient for every non-medicated person. And there's a very long reason of why that is, and we'll talk about that another time. But the legal ramifications here are, if a patient is not well, right? They're overweight, they have high cholesterol, they're pre-diabetic or diabetic, their risk for a cardiovascular event is higher. So if that patient is not put on a statin or diabetes medication, and that patient has a stroke or a heart attack and dies, the family or the estate of that patient will sue the doctor, and they will win, because the guidelines say, well, they should have been on these medications according to guidelines that are really laid out for insurance reimbursement purposes. So that's why healthcare is a big legal battle as well. Because if doctors are not following these guidelines, they can have their licenses taken away or be stripped of insurance credentialing or fired from their jobs. So it's become a real difficult, Wild West kind of environment in healthcare, where you can get in trouble if you're not following the right things. And I know doctors know better, and I know they want to do better, but they have their hands tied a lot of times, especially with big box medicine. So again, not legal advice, not healthcare advice, but this is something that happens. And if doctors deny it, they're lying. So it is a very well-known thing that happens in healthcare, that healthcare is driven by insurance. So that's why we don't use insurance, because we don't want to be nailed down to these restraints. So it's a
Wow,
very
that is
interesting topic.
really
Yeah,
yeah,
it's a
really
very
interesting.
Yeah, it's a very, very interesting and also very interesting, like sociological phenomenon going on with a major part of human interaction and human care for others. And, it's become a huge capitalistic entity, healthcare. Makes a lot of money. If pharmaceutical companies had cures for disease, they'd be out of business, right? They wouldn't make any money. So we can't cure people. That's not good for business. We have to keep them on medication for the rest of their life so we can make more money.
Yeah. I
Highly
mean,
controversial, but it's not a lie. I'm gonna hate to say it. So
yeah, so I mean, we're going a little in the weeds here, but I mean, this
yeah,
is just so interesting. I know so many patients become aware of this, and that's why they're attracted to practice like MedMatrix, because they, can
yeah,
actually escape that system and get care based on them, not on like their insurance or,
yeah.
the law, but actually what's best for them. Now,
Well, that's what we're trying to provide as like a full body, if we relate it back to our topic, right? We're trying to provide full body cardiovascular healing plan, right? That's what we're trying to do. And the basic principle of that is your insurance company will not pay for you to um, go through a healing journey. They will pay for you to have something wrong with you. They will pay for you when you have a heart attack or a stroke. They won't pay for you to be on the proactive side of things. So the Med Matrix model is to take people that are frustrated with the way their blood pressure is being managed, their cholesterol is being managed, really understand their risks of things. And that's really what we're doing best. So that's how we develop plans of healing for people the outside of the insurance model.
well, let me ask you a question that probably every single healthcare patient in the US is probably wondering. Why does insurance not pay for preventative treatments? Because the logic is that it costs a lot less to keep someone from getting sick than like medical bills rack up, man. I mean, a multi-million dollar end of life bill. So why not prevent that from
Yeah,
happening? Why don't insurances start investing in preventative care for patients?
because it's even more financially lucrative to do the opposite. It's
So
even
how are insurance, because insurance companies are the one paying for the medical procedure, so how are insurance companies profiting from spending money, if that makes sense?
they're profiting from drug therapy. Statins are the last statistic that I looked at. Statins have generated, I think, 200 or 300 billion dollars in revenue since they've been discovered. That's just one type of drug. So if we can make multiple different types of statins, multiple different types of blood pressure medications, this is a huge, huge money pit that these pharmaceutical companies can dive into. And the amount of money and resources and energy it would cost to do preventive health care, it's much easier to hire a group of chemists and scientists to create pharmaceuticals, sell them at astronomical prices, than create an entire team of people needed to get one patient well. Like if you take your example, Cole, 10 minutes ago of your guy, diabetic, overweight, what's easier? Creating a team of people to educate him on exercise, diet, blood work, visits, supplements, all of that, or create a pill. It's much easier to create a pill, and then be done and make a lot more money that way. So just that's the way it goes.
Yeah.
Fortunately, it's not like this in other countries. Other countries around the world in Europe, um, I mean, they're not. There's a lot of socialized medicine, which is a whole nother thing. But a lot of other countries have this mindset of preventive care, and they're much healthier. They're much happier. All the Nordic countries, Denmark, Sweden, they're the happiest people in the world because this is the way they live their life. But the American way is monopolizing, capitalizing. That's the American way. So why not do it to healthcare? That's what we've
Sure.
done. So
Yeah. So how does I guess that all makes tons of sense, and we see it, we
yeah,
hear it from patients all day long.
all day.
Are the so it's the pharmaceutical companies are obviously making all the money. It's a lot easier to just give a patient a statin medication than it is to, like you said, educate them
Definitely.
on nutrition, lifestyle, supplements,
Yeah.
fix their hormones, etc. So but the insurance companies are still the one paying for it, and the insurance companies are still for-profit companies.
Right.
So again, wouldn't it make more sense for the insurance companies to be preventive because it's their money, or the insurance companies in bed with the pharmaceutical companies? Why? How does
Yes,
that work?
exactly. They're all in bed with each other. So when when you have a new hospital being built, okay, or an extension of a big box medical group, any big medical entity in the world or any big city, New York City, Cleveland Clinic, whatever, pick one. To get money for a new wing of that hospital, who's paying for that? It's the pharmaceutical company. Well, we will give you, say, cancer, perfect example. We will give you $1 billion to build a new cancer hospital, whatever it costs, make up a number. But in the contract, your providers in that new cancer hospital have to prescribe our drugs. So we gave you $1 billion to invest in this new entity, but we will make $100 billion back because all the revenue that's generated by that new hospital, medical center, whatever, goes back to the pharmaceutical company, and then it also funnels through the insurance company. So the insurance companies make, because they're the middleman, right? The insurance company is making all the money on the premiums, and the pharmaceutical company is making the money because they're selling it through the insurance. So it's all a vicious cycle go around. So if the insurance companies were to invest money in preventive healthcare, then or say a medical entity like a hospital was to invest in health prevention, then the insurance company and the pharmaceutical companies would make no money. So then how are the investments going to come back? How's the hospital going to make money? It's all a big cycle around. So
Yeah. No, I
yeah,
mean it's true. I mean, unfortunately, people will go into debt to save their life for obvious reasons, right? I
yeah,
mean, if you're dead, your money doesn't matter, so sure. But
yeah.
yeah, so I mean that makes sense.
And heart disease is one of the biggest feeders
Right.
of this cycle,
Right.
right? Hence why we're talking about this. Like I said, I think the current stats on statin profit is like 200 or 300 billion dollars, and that's just one type of drug. We layer in the hypertension drugs, the diabetes drugs. I mean, you've got one patient who's like your example, Cole, from earlier. If he's on a statin, a diabetes drug, and a hypertension drug, a lot of people are making a lot of money off of that one person. And then what happens is the regulations and the rules around how we treat that patient are such that you have to give them the statin, the diabetes drug, the blood pressure drug. And if you don't, you're legally responsible. But the reason why they created those standards is so that all of this feeds back to make money off of. So it's a really, really ugly thing. And I'm sorry we're talking about it in this way, but it's really important. And
Yeah.
patients are not stupid and they're not ignorant, and they get it, especially with the advent of social media and the digital age where we can share information. They are not uneducated, and they are starting to realize that their doctors, for whatever reason, are not as interested in trying to help them or make them live longer or prevent cardiovascular risk. It's really just sticking them on meds and scooting them out the door. So, but again, that has its place, not denying that, but not for everybody. So,
Mm.
yeah.
Yeah. Wow. I mean, that was a great. I learned. I mean, I already knew a lot of this, but the way you described it was very helpful, and I definitely learned a lot more. So, I mean, I think you're totally right. A lot of people are. It's less of like people know it to the degree that you do, and more they're aware that something's going on. Like this doesn't feel
Yeah.
like the type of
Yeah.
healthcare that people want, which is cool that we're able to do it. And then Matrix would be great if this is something that insurance paid for. Maybe I guess do you
Maybe
I'll ask you a
someday.
speculative question. Do you think because I mean ultimately it's like if everyone in the US wanted this type of healthcare, like we would be there
Mhm.
overnight. Do you think that services that MedMatrix provides with preventative medicine, root cause medicine, could one day be covered by insurance?
I want to hope so, because in the last I'm in my mid 30s, right? When I was a kid, um, I don't think it was that long ago, right? It wasn't like 100, 200 years ago. There was no internet, there was no social media. You had to listen to your doctor. You went to the doctor, you had to listen to what they said. And if you questioned it, they'll fire you, right? Don't question my authority. I'm the doctor. Okay, well, whatever, and you'd be fired and you'd have to find a new doctor. And so nowadays, in a very short period of time, right, we've developed internet, social media, AI. I mean, this is in the last 10, 15 years, it has ramped significantly. So if we keep ramping at the way we're going from like a digital age and technology focused culture, there's good and bad to that, but we're able to give people so much more information, and they can start questioning the things that they do and questioning the information they've been given by this authority, right? Their doctor, not, being disrespectful, but it's an authority, potentially. So as we continue to grow in our culture and in the way we do things, what's going to start to happen is there's a demand by the masses for better, right? A demand for better healthcare, a demand for better options, a demand for better understanding of patients' illness and their conditions. And this was a big thing. This is totally off topic, but this is a big thing that happened with COVID, right? COVID happened, and we were forced because of patients demanding we need to learn about this more. So we were forced to learn. So I think it will happen with demand from the general public. It's just, how does that play out, right? How does that play into multi-billion dollar insurance companies, pharmaceutical companies, healthcare entities? I don't know. I don't really know how it plays out, but I think it will. In my lifetime, I think it will dramatically change, and I hope to see it continue to change. But I hope it doesn't leave a lot of people behind, which is a lot of times what shift can happen. If you can't afford it or whatever, then it's not accessible to you. So I hope it changes. I just don't know how the logistics of the change, but it is changing. People are becoming much more knowledge minded about stuff. They're questioning their doctors. They're questioning what's being done. They might not have the answers, the patient, and they might not know where to go, but they're at least starting to question the relationship, what they're being told, and what care they're being given, which is a great thing. Because then when patients find us and we can educate them in another way, and they really bond with us and the way we do things, it creates a whole new space for the patient and a whole new projection, a new trajectory, and a new life. And it's really cool to see patients change their perspective on this in front of your eyes. I see it all the time, and it's really miraculous.
It's pretty cool. So
Yeah.
let's we got a couple more minutes here, so let's kind of go back to the topic of high blood pressure, statins,
Yeah.
medications, etc. Let's talk about the role of your sex hormones and cholesterol.
Yeah.
How does having low cholesterol, or I guess low cholesterol because of taking statin medications, how does that connect to your sex hormones, and how can that cause an issue with motivation?
Yeah. So like I said earlier, one of the biggest issues that I see with my patients, especially men, women too, but it's more obvious in men, I think, because women can have a very abrupt change in their hormones with menopause. I mean, there's perimenopause that changes over time, but both men and women, when they have a reduction in their hormone level as they get older, as part of the natural aging process, if those people are put on cholesterol medication for whatever reason, not saying it's good or bad, just saying, let's just assume they're put on it. If you do that, you're creating a piece of the puzzle that can't do its job. So cholesterol is one of the major building blocks of hormones: testosterone, progesterone, estrogen, cortisol. So if a guy has low testosterone and he's on a really high cholesterol medication, we could make a very strong inference that they're related. So if he is complaining of low libido, low fatigue, brain fog, he's not as sharp at work, he can't do a full day at the office, he's having side effects of the statin because fatigue, muscle weakness, all of that is also, we talked about that earlier with coenzyme Q10 and other minerals that are reduced by cholesterol. So there's a huge connection here. And it's really important to understand what the need is for the cholesterol medication. How do we treat this patient, right? How do we optimize his hormones? If he needs cholesterol medication, can he stop the cholesterol medication? So there's a huge link here for sure. And we see it every day.
Gotcha. So what's the difference between HDL and LDL, and why do they call LDL bad cholesterol?
HDL is the good cholesterol. So you want optimal for HDL is above 50, 50, 60, something like that. A lot of times men cannot optimize their cholesterol because, or their HDL. There's some genetic issues there where sometimes men have lower HDL genetically. And then LDL is considered the bad cholesterol because, like I was saying earlier, if LDL is met with other issues like insulin resistance, inflammation, what happens is the LDL oxidizes and it becomes smaller, and then it starts creating plaque. So the role of LDL is it brings plaque to the heart. HDL brings it away. So the HDL is going to be cardiac protective, whereas the LDL has the potential for plaque formation. So the physiology of how they function.
Gotcha. Okay, so that's why they call it good versus bad cholesterol. That makes sense.
Yeah.
All right. But LDL is important, right? Like you need LDL.
Yeah. It's all very important. Otherwise we wouldn't have it. That's the thing that's really interesting. It's like, whatever you believe in, if you believe in a higher power, if you believe in the power of evolution, a God, whatever, the human body is miraculous in the way it functions, and all the different intricacies of life and conception and just like how we breathe and our heartbeats. And if you stop and think about it, it's really miraculous how humans function. And it's really, really cool to look at a really small molecular level. But the biggest thing in healthcare and in medicine is like turning off all this stuff. Like, all right, reducing your cholesterol and reducing this and reducing that and turning off this enzyme. And it's like, why are we trying to turn everything off? Like, that just doesn't make logical sense. If we weren't built the right way, wouldn't something have changed by now? So we are built the right way. That's the thing. We don't need to get rid of all this stuff. We don't need to take gallbladders out all the time. We don't need to take, uteruses out all the time because they're dysfunctional, but that's the healthcare way. If it's dysfunctional, take it out. Well, no, then we're just like, this doesn't make sense to me. There's a reason for all this stuff. And the understanding from a good provider is, well, if it's dysfunctional, why is it dysfunctional? Don't get rid of it because it's dysfunctional. Figure out why it's dysfunctional.
Well said. Yeah, and that makes common sense. Right.
Yeah.
Good stuff.
I think so.
All right, then. Cool. All right, guys, we're wrapping up here with the last few questions. If you are joining us live, feel free to comment, make some comments. Looks like we have a few people left, so make some comments. If again, we can't give medical advice, but we can answer broad questions if you have anything like that. Let's talk about peptides. One of the things we do a lot. How have you used peptides to help patients get off statin medications, lower their LDL, lose weight, so on and so forth?
Well, it's hard to say you'd use a peptide to lower cholesterol. That's a little bit specific, but certainly the GLP-1 drugs, which are peptides, the drugs that are most commonly used for weight loss, can lower cholesterol. So the thing that we try to do with peptide therapy at MedMatrix is use the peptide to correct some of these imbalances. Like I said, if it's insulin resistance, we can use GLP-1s, we can use anti-inflammatory peptides to control inflammation. We can use peptides for weight loss. We can use peptides for growth hormone optimization. All of those things are really important to reduce the inflammatory response, get insulin working better, which would in turn improve your cholesterol issues.
Okay, let's talk a little bit more about inflammation. Like, what is inflammation? Because you hear it all the time. People are like, "Oh, I'm inflamed. Reduce inflammation.
Oh
Inflammation is
boy.
the root cause of all disease." Like, in 30
Yeah.
seconds or less, what is inflammation and why is it bad?
From a cardiovascular perspective, inflammation is usually related to, as I mentioned earlier, and we've mentioned on the podcast before, damage to the endothelium, which is a single cell layer that is inside the blood vessel, the vascular system. So when you damage the endothelium, it impairs nitric oxide production. Nitric oxide is a gas that is inside of your bloodstream. Nitric oxide helps expand your blood vessels and helps give blood and nutrients to the tissues. So if you damage with inflammation your endothelium, it's going to directly impact the ability for blood to get to tissue. So things like ultra-processed foods, seed oils, toxin exposure, all these things will cause inflammation, hence damage your blood vessels. But
That makes sense. So that was a great.
inflammation is extremely broad. There's a lot more to it than that. So, but that's
Yeah.
how it relates to cardiovascular health.
Okay, gotcha. And then
Yeah.
what is the broad definition of inflammation and health?
Inflammation is driven by what you do to your body, what you're exposed to, the food you put in your body, chemicals you're exposed to. And what inflammation does is it dysregulates every single metabolic function you have, whether it's production of hormones, production of immune system cells, regulation of your blood sugar, your brain chemicals, your gut health. So anytime tissue is inflamed in the body, it creates a local effect that causes a disruption in what's going on to regulate hormones, regulate nervous system function, regulate gut function. So inflammation can affect anything. If you think about, if you get a mosquito bite, and you've got like this inflamed mark on your hand, on your skin, and it's red and it hurts or something, imagine that throughout your whole body. It's not going to make you feel very good. Imagine that in your blood vessels. That's not going to work, or in your brain. So that's the best way to explain it.
Okay. Yeah,
Yeah.
gotcha. Thank you.
Yeah.
Thank you. All right. Let's see. I'm trying to think of one question to take us home. Okay, why like there I actually see a lot of guys out there who are in good shape, but they are still on a statin medication. It,
Good question.
yeah, so
Yeah.
what what's going on there? Like why are you on a statin if you're in shape?
Well, it's these people that are doing everything right, quote unquote, right? Like I'm doing everything right. My diet's good. I work out, but I still feel inflamed. I still feel unmotivated. I've been put on a statin. So there's something going on with those people. And a lot of times, to answer your question directly, if they're on a statin, it could be that the cholesterol is a little bit high. So some provider said, "Oh, your cholesterol's 220. It needs to be under 200. Here's a statin. Get out of my office," kind of thing. Or your cholesterol's a little bit high. You have a family history. You need to be on this. Okay. So it might have nothing to do with the rest of them. A lot of times in the healthcare system, medications are prescribed based on a laboratory result. Nothing else. Sometimes, if the cholesterol is over 200, the LDL is too high, they will just, here you go, here's your statin. It doesn't matter what your diet is. It doesn't matter if you're working out. It doesn't matter how old you are. It's just, we need to regulate this lab result so that we can put you below that threshold, so I'm not legally liable in case something happens to you. So that's really the straight answer, Cole, is usually it reflects a high lab value, and oftentimes nothing else. But to broaden the answer to a question like that, somebody like a guy anybody, a male, female, that's doing everything right, diet, meds, working out, they might feel like they're doing everything right, but they might not have the education that they need to make good diet choices. They're making diet choices that they feel are right that are maybe not right for them. Or they're working out in a way that they feel is right, but it's not right for them. Maybe they're overtraining. Maybe they're not doing enough weight training. Maybe their, hormones are imbalanced. Maybe they have low T, perimenopause. So that's really what we're trying to accomplish at MedMatrix, is get a full picture understanding of people. But like I said, oftentimes the reason why drugs are prescribed is because of some lab value that was off. And that's really it. That's like,
Hmm.
it's really bad healthcare. I think, because it doesn't speak to the person and what they need and their longevity. It's really just satisfying a lab result, and it's very reductionist.
That's very interesting. Yeah,
Yeah,
man. I mean, imagine a lot of patients aren't actually even. They might be okay. Something seems off, but I think that was a good explanation.
yeah,
All right. I got one last question here, then we'll rattle off a few questions from the comments.
sure.
What is your, and this is going to be helpful for patients who are considering coming to work with us as a practice who are on a statin medication and want to get off a statin medication. What role can you play as a functional medicine provider at MedMatrix in getting a patient off a statin medication? Because you're not just going to go to their PCP and like just scratch out the prescription. You're not going to do that.
No,
So
no.
what role do you play in that? And then how do you actually go about getting a patient off of statin medication?
One of my big roles is providing the patient a space to educate them on their health. A patient may be 40, 50, 60 years old and really have very little understanding of health and what health really means, right? What labs mean, what diagnoses mean. I hear this all the time when when I review lab data with patients and they say, "Wow, I really am happy and appreciative of how you tied all that together for me. No one's ever done that before." So if I can do that for a patient, that starts to set the ball rolling on their health journey, right? I'm not going to fix people overnight. That's not a thing. A week's going to go by and they're still going to be overweight, right? So my job is to start putting the pieces together, right? The healthcare system puts the patient in all these different boxes, right? You got a thyroid problem, you see the thyroid doctor. You got a heart problem, you see the cardiologist. You've got menopausal problem, you see, the OBGYN or whatever. So my job is to start putting their health together and educating them on how to be healthy, how diet affects them, how exercise affects them, how their lifestyle affects them. So from a functional medicine approach, that's one of my biggest goals is starting to educate. And then what we're trying to do is bridge gaps, right? Do advanced testing that's never been done so that we can start to put the pieces together. And that's really the Med Matrix method. The title of our podcast is to put these pieces together with advanced blood work, with understanding their health history, so we can start to educate and treat. So when we start to treat, when we start to get patients better regulated, better balanced, then it's about discussions about medication, right? Is the medication needed anymore? Right? I've reversed diabetes. I don't know how many times. How many patients have told me, "Oh, my doctor said diabetes is not reversible." Well, that's crap. I've reversed it many times. They're not going to tell you that because they don't know how. They don't have the time. They don't have the knowledge. So the goal is trying to work with people's doctors, trying to work with them, not only get them healthy, but mitigate their need for medication. Not that medication is outwardly bad, but we don't need everybody medicated for everything. That's not healthcare. That's just, lining up in a line and giving people pills.
Mm-hmm.
So
Gotcha.
that's really the job of us as functional medicine providers, specifically at MedMatrix, is to do this work for people, put the pieces together, get their journey going, and really educate them to see things in a different way.
Awesome. Well, thank you. All right, guys, if you're joining us live or you're watching a recording of this and you want to work with someone like Dr. Nard or anyone else from the wonderful medical team here at MedMatrix, you can go to medmatrixusa.com and you could click get started and you can have a conversation with a patient coordinator and see if, we could help you reach your health goals. Now, we're going to answer one question here from the comments from the live stream. That's all we have time for. Do grounding mats work?
Yes, grounding
They
is
do.
great.
Okay.
Yeah. Yeah, one of the biggest issues that is seen with any sort of complex disease or disease in general is nervous system dysfunction. So even with high blood pressure, nervous system dysfunction is a big one. So I've had a lot of patients with complex childhood trauma, emotional abuse, sexual abuse, abuse by a partner or something. There's all kinds of traumas on the body that we accumulate over the years, and we wear that. We wear it in the way our body functions, the way our body works. So grounding is a great method to start retraining your nervous system to function properly. And there's a lot of research about the grounding mats are really helpful, but really grounding by definition is getting outside, putting your feet in the ground of nature and really absorbing the different frequencies of the ground and the earth, and the energies that offers to you. For a lot of people, it can sound very woo-woo and a little bit like, oh, that's too out there for me. But grounding is an ancient practice that humans have been doing forever. And it's a really, really great way to regulate your nervous system, which is a great starting point of helping to heal. So I think they're great. But if you can get outside, even better, But if it's the middle of winter, right, in Maine, and it's freezing, use a grounding mat. Yeah.
Nice.
Yeah.
All right, guys. Well, Dr. Renaud, thank you so much for your time. Thank you for everyone who
Thanks,
tuned in
Cole, for
live.
having me.
Yeah, always happy. Super excited to do more of these. That was a super interesting episode. Again, if you're interested in becoming a patient, go over to medmatrixusa.com, click get started, and we'll see you there. All right, everyone. Thank you so much for joining.
Thanks, guys. Bye-bye.